Thanks for watching. So now today we are going to discuss abdominal pain, and I want you to take from this lesson the basics and the very absolute basics that you will need in clinical life, and also if you are in a state of examination where you need to examine and assess a patient with acute abdominal pain. Remember always to keep it simple, as simple as possible, but not simpler. And when we talk about the abdominal pain, we will have to divide the abdomen into several areas or regions. And these regions are determined by two vertical lines and two horizontal lines. The vertical lines are the ones that pass from the mid-clavicular region right down to the mid-inguinal point. Same thing on here. Mid-clavicular point to mid-inguinal ligament point, and two horizontal regions. The transpyloric plane, which runs across the lower edge of the ribs, and the plane that runs from the right to the left anterior superior iliac spine. Now, what will that give us? It will give us 9 regions, and these regions are right hypochondrium, epigastric, left hypochondrium, 2 lumbar regions, paraumbilical area, right iliac fossa, left iliac fossa, and hypogastrium. So when you say the patient is having pain, try and specify where is the pain, or at least where did the pain start? Did it spread or not? So specify the areas of the abdomen. Now we move further. In each of these spots, there will be a differential diagnosis to the pain that arises from any one of those 9 areas that we mentioned earlier. And I always advise students and young doctors that when you get asked to see a patient with acute abdominal pain, while you are on your way to see the patient, just try to psych yourself up. And I'm sure they would have described the patient to you, presented them over the phone from the emergency department. And then you start to think about what could be wrong with with that patient. The possibilities are variety. It could be anything, but in most of the cases, the cause of the abdominal pain will be very common, and the numbers are easily remembered. So if someone has pain in the right upper quadrant, then the first thing that comes to our mind is the biliary tree and the liver. Disease of these things: gallstones, cholangitis, liver abscess, large tumor in the liver, anything in relationship to gallstone disease. If it is in the epigastric region, then our differential diagnosis could be pancreatitis or peptic ulcer. Now, always think about pancreatitis when you have abdominal pain. Always think about pancreatitis, because it could look like any other acute abdominal condition. So it mimics anything else. So always keep it in mind. Left upper quadrant, splenic abscess, acute enlargement of the spleen or splenic rupture. These things, though, are quite unusual, and they only happen in certain circumstances. When you have central abdominal pain, you will need to think mainly of pathology related to the small bowel, which could be in the form of small bowel obstruction, regardless of the cause. We will discuss small bowel obstruction in thorough details in another lesson. Mesenteric lymphadenitis could be, a mecal diverticulitis, appendicitis can be, the cause of that. And so on and so on. Ruptured abdominal aortic aneurysm. The pain could be non-specific. The pain could be caused by perforated viscus, and that can be anything. And the most common perforated viscus, if it happens spontaneously, we know it is a peptic ulcer or perforated diverticulitis. We should always think about the urologic tract and also the female genital tract. And don't forget the groin areas, because hernias can cause bowel obstruction and they can lead to acute abdominal pain presentation. And the elderly patient could not be aware of any lump in the groin. So you need to ask them specifically, and you need to examine the area, obviously. Now, a few things that generally you need to put in your mind and always remember is the following two things. Ischemic bowel. Now, small bowel ischemia can be either embolic or as a result of low volume flow. That will get discussed at later dates, but think about ischemic bowel because it also can mimic any problem. Usually these people are elderly, they have chronic vascular disease in general. They very well could be smoker, hypertensive, and have a history of peripheral heart disease, or peripheral vascular disease, or ischemic heart disease, or they have chronic renal failure, or they are diabetic. That will give you a clue. The abdominal pain, I emphasize on it and this condition because it can be really vague and difficult to diagnose. Now, we move on. These things are, in fact, very preliminary, and we will emphasize on all these aspects in different places according to the diagnosis that we will find. But I want you to assess a patient with abdominal pain and make the primary form of management. Now, history is one of the most important skills in clinical life. If you take good history, it will help you a lot to manage the patient, hopefully pick what the problem is, and will be able to rectify that. Build the rapport with the patient. Very important that the patient feel they are safe, they're not threatened, and they are in a friendly, caring situation. And a few words of reassurance, a few sentences in general, which could be related to the family, the weather, or any thing, in fact, can lead you to get the patient closer to you. The more they like you, the more they trust you. And so you put them to rest, make them relax, make sure you acquire that sort of skills. It comes with experience, but make sure you do have it in mind and be in that mode before you ask any question. Now we will go to the abdominal pain and do a little bit more details about how we take history from someone with pain. So what we will ask the patient about is onset of the pain. How did the pain start? Did it start in a sudden type of mode? Was it a gradual pain that was grumbling for a while and kind of creeped up on them over a few hours period of time? We know that pain that is gradual is usually caused by infective or inflammatory problems, while sudden onset pain is caused either by perforated viscus or bleeding. So we need to ask about the site of the pain. The site of the pain is related to the places and the regions of the abdominal area that we mentioned in the previous slide. We ask the patient about the type of the pain. Now, this is probably the most difficult one to assess because it will depend on the patient experience and what they have, what they had in the past, which means that I try to approximate that to them. Say, was the pain sharp? Is it just dull like a toothache? Is it pain that is sharp, cutting? Like cutting with knife? Is it crampy, like a colicky pain? So try to suggest some words to them if they feel lost and they cannot describe it. Severity of the pain. Give them a scale of 1 to 10 and ask them how bad it is on that scale. Now, this is very subjective and you get different answers from different patients, but we have to take it at face value and we document it and treat it as the patient says. Any radiation of the pain. Now, pain could radiate, say abdominal pain could radiate to the back in biliary and pancreatic problems. Ruptured aneurysm could radiate to the back and to the groin. Pain from biliary tree can radiate also to the shoulder, and so on and so forth. Renal colic will radiate from the loin down to the groin region. We always need finishing asking the patient about the pain. We then go on to look for other symptoms related to the GI tract, and these symptoms are the following. Does the patient have nausea? Have they vomited? How many times they vomited? Was there? And then you emphasize on the vomit if there is. Is there any blood in it? The color of that, was it feculent? Was it bile? Was it blood? And also the quantity. And you ask about the frequency of the vomiting. We'll give you great details about the patient. How was their appetite? And that's usually during the illness or the day or so leading to the illness. And whether they had opened their bowel, are they constipated, are they having diarrhea? And if they are having diarrhea, then we go on and try to describe that. Is it watery? Is it just loose? Is there any blood in it? Is there anything else the patient would like to add? Then we ask them about any symptoms related to the urological tract. And the only thing is that you ask them is whether they had previous kidney stones. Do they have previous experience with renal colic? Are they passing urine easily? Is there any frequency, any burning, micturition, any blood with the urine? We need to ask them whether there is any lump in the groin, and that's relevant to small bowel obstruction and hernias, particularly femoral hernia in elderly patients. The patient often is not aware of the fact that they have got a hernia, and you need to pay close attention to that and test it. And then you need to ask patients about the female genital tract, and that will involve a history about how many child they had, what sort of delivery, whether they are normal deliveries or cesarean. Was there any complication following any of those? Was there any operation performed on the ovaries and the uterus, and also the monthly cycle, and when where they are in their 4 weeks cycle? That would help you to in the differential diagnosis of a variety of things: contraceptive use, intrauterine device use, and the type of those, and so, and also if there's any vaginal discharge, then you need